Hello everyone, I am Dr. Nikita Vijay, Associate Professor from the Department of Obstetrics and Gynecology, NKP Salve Institute of Medical Sciences and Research Institute. This video is about the shoulder dystocia. Shoulder dystocia can be defined in two ways. When after the delivery of fetal head and additional maneuvers are required to deliver the fetal shoulder, or in other way when the head to body delivery interval time exceeds 60 seconds. Shoulder dystocia is a bony impaction. Commonly anterior shoulder is impacted behind and above the pubic symphysis, and sometimes posterior shoulder is impacted above the sacral promontory, or very rarely both the shoulders are impacted. Coming to the risk factor for shoulder dystocia. Risk factors are antenatal and intranatal. Antenatal risk factors include prior history of shoulder dystocia, fetal macrosomia, gestational and over diabetes mellitus, maternal obesity, post-term pregnancy, and anencephaly. Intranatal risk factors include induction and augmentation of labor, prolonged first and second stage of labor, secondary arrest of labor, and instrumental delivery. However, in majority of cases, no risk factor is identified. Coming to the complications of shoulder dystocia. Complications can be maternal and fetal. Maternal complications include postpartum hemorrhage, perineal injuries in the form of vaginal laceration, cervical laceration, and 3rd and 4th degree perineal tear, increased operative interference. Fetal complications include fetal hypoxia or hypoxic ischemic injury, brachial plexus injury in the form of Erb's and clump case plexopathy, fracture humerus and clavicle, sternomastoid hematoma. Coming to the diagnosis of shoulder dystocia. Timely management requires prompt recognition. Shoulder dystocia can be diagnosed as the failure of complete restitution of fetal head, failure of shoulder to deliver on gentle downward traction, or retraction of fetal head over the perineum. This is called as the turtleneck sign. Coming to the management of shoulder dystocia. Shoulder dystocia is an obstetric emergency. Ongoing cord compression is the reason behind the emergency. Management principles include minimize head to body delivery time and balancing this act with the minimal perineal trauma with the rapidity of maneuvers to release the fetal shoulder. There are some do's and don'ts to be followed to manage the shoulder dystocia. Do's are: call for the extra help, involve your colleagues, nursing staff, senior obstetrician, anesthetist and neonatologist, clear baby's mouth and nose, evaluate for the wide mediolateral episiotomy to perform various maneuvers later on. Don'ts are: do not become panic, do not give traction in the lateral and downward direction, this will further aggravate the condition. Do not give fundal pressure, do not encourage the mother for the further pushing. There are various maneuvers to release the fetal shoulder. First line maneuvers include macrobus maneuver and suprapubic pressure. Second line maneuvers include delivery of posterior arm and various rotational maneuvers like Rubin 2, Bush screw maneuver, reverse wood screw maneuver. Third line maneuvers include clidotomy, symphysiotomy and Javanelli maneuvers. Each of this maneuver is designed to do one of the three things. Either they increase the functional size of bony pelvis, or they decrease the bisacromial diameter, or they change the relationship of shoulders bisacromial diameters within the bony pelvis. Now we will demonstrate the various maneuver to manage the shoulder dystocia. First is Make Roberts maneuver. As we don't have proper maternal dummy, we will demonstrate the Make Roberts maneuver in the fetal dummy. Here, maternal thighs are abducted and sharply flexed over the maternal abdomen. This causes straightening of sacrum, rotation of pubic symphysis upwards, and decrease in angle of pelvic inclination. Suprapubic pressure should be used to improve the effectiveness of Make Roberts maneuver Suprapubic pressure is applied by an assistant towards the side of fetal chest, either using one hand or both hands. This reduces bisacromial diameters and rotate the anterior shoulder towards the oblique diameter. Make robust maneuver is simple, rapid and effective intervention and should be performed first and can solve the problem in majority of cases. Second line maneuvers are delivery of the posterior arm and rotational maneuvers. The most spacious part of the maternal pelvis is in the sacral hollow. Therefore, vaginal assist should be gained posteriorly into the sacral hollow. Then delivery is facilitated by the rotation into the oblique diameter or by the delivery of the posterior arm. First rotational maneuver we will demonstrate is Rubin 2. Here, operator insert two fingers into the posterior vagina and then bring them behind the anterior shoulder, and shoulder is pushed anteriorly towards the fetal chest. Wood's corkscrew maneuver can be combined with the Rubin 2 maneuver. Here, two fingers are behind the anterior shoulder and two fingers of other hand is in the front of the posterior shoulder and rotate the shoulders in oblique diameter. Reverse Wood's corkscrew maneuver. Two fingers are placed behind the posterior shoulder. An attempt is made to rotate the fetus in opposite direction as the Wood's maneuver. All these rotational maneuvers rotate the fetal shoulder out of the impacted position into an oblique plane from which they can deliver. Next maneuver is delivery of posterior arm. Here hand is introduced through the posterior vagina behind the fetal arm till the elbow, then flex forearm is swept along the fetal chest and arm is extended in front of face and delivered out. Gaskin or the all four maneuver. This maneuver requires the patient to roll from the existing supine or dorsal lithotomy position to an all fours position. Precise mechanism by which this maneuver acts to relieve the shoulder dystocia is unknown, although it has been documented that the pelvic diameters increases when the laboring woman changes from the dorsal recumbent position. Third line maneuvers should be considered very carefully in those cases which are resistant to all standard measures. They are clidotomy, that is the surgical division of clavicle or bending of clavicle by the finger, and symphysiotomy, that is the division of anterior fibers of the symphysial ligament, and Javanelli maneuver, that is the fetal head is replaced back into the vagina and delivered by the cesarean section. There is no evidence that any method is superior to another. Up to 30 seconds is recommended as the appropriate amount of time to spend on each maneuver. Each institute should have a layout for the shoulder dystocia drill and should be regularly practiced to manage this condition efficiently. Helper mnemonic can be used to perform the shoulder dystocia drill. Here H stands for the call for help, E stands for the evaluate for the episiotomy, L stands for the legs, that is abduction and hyperflexion of legs in the macrobus maneuver, P stands for suprapubic pressure, E stands for enter for the rotational maneuvers, R stands for the release of posterior arm, and one R stands for the roll the patient to all four position. This is all about the shoulder dystocia. Hope all of you have understood how to manage the shoulder dystocia using various maneuvers and using the helper mnemonic. Have a safe delivery. Thank you.